Osteoporosis is a condition characterized by decreased bone density and increased risk of fractures. Here's a brief review. Pathophysiology, bone remodeling. Osteoporosis results from an imbalance between bone resorption by osteoclasts and bone formation by osteoblasts, leading to a net loss of bone mass. Bone density loss. This loss of bone mass leads to weakened bones that are more susceptible to fractures. 2. Risk factors. Genetic, family history, age, and gender. Women are more affected due to hormonal changes post-menopause. Lifestyle, smoking, excessive alcohol consumption, and lack of physical activity. Medical conditions, conditions like rheumatoid arthritis, chronic kidney disease, and malabsorption syndromes. Medications, long-term use of corticosteroids and some other medications can increase risk. Diagnosis, bone mineral density, BMD testing. Dual energy X-ray absorptiometry, DEXA, is the standard method for diagnosing osteoporosis. Fracture risk assessment. Tools like FRAX can estimate fracture risk based on clinical risk factors in BMD. F4, management. Lifestyle modifications. Adequate intake of calcium and vitamin D, regular weight-bearing exercise, smoking cessation, and limiting alcohol intake. Medications. Bisphosphonates, alendronate, risdronate. Denosumab, monoclonal antibody that inhibits osteoclast activity. Selective estrogen receptor modulators, CRMs, raloxifene. Hormone replacement therapy, HRT, for postmenopausal women. Teriparatide, parathyroid hormone analog for severe cases. Fall prevention, measures to reduce the risk of falls, such as home safety modifications and balance training. 5. Prognosis. Osteoporosis is a manageable condition, but it requires ongoing management to prevent fractures and maintain quality of life. Let me know if you need more specific details on any aspect. Osteoporosis exhibits significant variations based on age, sex, ethnicity, and geography. Here's a closer look at each factor. #1. Age variations. Age-related bone loss. Bone density peaks in the early 20s to 30s and begins to decline gradually after the age of 35 to 40. The rate of bone loss accelerates with age, particularly after menopause in women. Older adults. Osteoporosis primarily affects older individuals, especially those over 65. As the body ages, the ability to maintain bone mass diminishes, leading to increased risk of fractures. #2. Sex differences. Women. Osteoporosis is more prevalent in women, especially postmenopausal women. This is due to the sharp decline in estrogen levels after menopause, which leads to accelerated bone loss. Postmenopausal osteoporosis. Nearly 1 in 3 women over the age of 50 will experience an osteoporotic fracture. Men, while less common, men are also at risk, particularly after the age of 70. Men experience a more gradual decline in bone density, but when they develop osteoporosis, it tends to be underdiagnosed and undertreated. Secondary causes. Men may develop osteoporosis secondary to conditions like hypogonadism or the use of corticosteroids. #3. Ethnic variations. Caucasians and Asians. These groups tend to have the highest rates of osteoporosis. In particular, postmenopausal Caucasian women have the highest fracture risk. African Americans. They tend to have a higher bone mass and lower risk of osteoporosis compared to other ethnic groups. However, when fractures do occur, the morbidity and mortality rates can be higher. Hispanic populations. While traditionally thought to have lower risk than Caucasians, newer studies indicate a growing prevalence of osteoporosis among Hispanic individuals, particularly women. Native American and indigenous populations. Data on osteoporosis prevalence is limited, but these groups are thought to have intermediate risk levels, often influenced by lifestyle and access to healthcare. 4. Geographic variations. Developed versus developing countries. Osteoporosis is more commonly diagnosed in developed countries, possibly due to greater longevity and access to screening tools like DEXA scans. However, the global burden is increasing due to aging populations worldwide. Northern versus Southern Hemisphere. Countries in the Northern Hemisphere, particularly in Europe, the United States, and parts of Asia, have higher reported rates of osteoporosis. In contrast, regions in Africa and the Middle East tend to have lower reported rates, although this may be due to underdiagnosis. Dietary and lifestyle factors. Areas with lower calcium intake, e.g., parts of Asia, or lower vitamin D levels, e.g., northern latitudes with less sunlight, may experience higher rates of osteoporosis. Conversely, populations with high physical activity, especially weight-bearing exercises, tend to have lower risks. Global incidence trends. Western Europe and North America. These regions experience the highest incidence of hip fractures due to osteoporosis. Asia. With aging populations, Asia is expected to see the largest increase in osteoporosis-related fractures in the coming decades. Middle East and Africa. Although less common historically, the prevalence of osteoporosis may rise with increased urbanization and sedentary lifestyles. Understanding these variations helps in tailoring prevention, diagnosis, and treatment strategies across different populations. The idea that osteoporosis fractures are less common in hot countries due to increased sun exposure and higher bone strength, even with lower bone density, is partly fact and partly myth. Here's why. 1. Sun exposure and vitamin D. Fact. Sunlight is a key source of vitamin D, which plays a crucial role in calcium absorption and bone health. Countries with higher sun exposure, particularly in hot climates, may have populations with higher levels of vitamin D. This can contribute to better bone mineralization and overall bone strength. Vitamin D and bone health. Adequate vitamin D helps in the absorption of calcium from the gut, promoting stronger bones. Individuals in sunny regions often have higher natural vitamin D levels, potentially reducing the risk of osteoporosis and fractures. 2. Bone density versus bone strength. Myth, in part. While vitamin D contributes to bone health, higher sun exposure alone does not necessarily compensate for low bone density. Bone strength depends on both bone density and bone quality, which includes bone microarchitecture, turnover rate, and other factors. Low bone density risk. If bone density is low, fracture risk remains high, even in populations with adequate vitamin D levels. Sun exposure cannot completely offset the risks associated with significant bone loss. Fracture risk. Studies show that despite differences in sun exposure, factors like age, sex, genetics, and physical activity are more significant determinants of fracture risk than sunlight alone. 3. Geographic fracture data. Cold countries. Fracture rates tend to be higher in colder countries like Northern Europe and parts of North America. One reason is less sun exposure, leading to lower vitamin D levels and consequently lower bone strength. Additionally, icy conditions increase fall-related fractures. Hot countries. Some studies show that fracture rates in sunny, tropical regions, e.g., parts of Africa and the Middle East, are indeed lower, but this is also influenced by lifestyle, diet, physical activity, and genetic factors, not just sun exposure. 4. Lifestyle and diet considerations. Physical activity. People in hot countries may also engage in more outdoor activities, which contribute to stronger muscles and bones through weight-bearing exercise, further reducing fracture risk. Diet. Traditional diets in some sunny regions may also be richer in bone-friendly nutrients, e.g., calcium from dairy or vitamin D from oily fish, which can contribute to lower fracture rates. Conclusion. While sun exposure and the resulting higher vitamin D levels do provide a protective effect on bone health, they do not completely prevent osteoporosis or fractures in individuals with low bone density. Bone strength is a complex interaction of factors, and while fractures might be somewhat less frequent in sunny regions, it's not solely due to sun exposure. Therefore, this concept is a mix of fact and myth. The statement that osteoporosis is less common among obese people is generally a fact, but with some nuances. Here's a breakdown. 1. Protective effect of obesity. Increased bone density. Obese individuals tend to have higher bone mineral density, BMD, which is a protective factor against osteoporosis. This is because the excess body weight increases the mechanical load on bones, stimulating bone formation and maintaining bone mass. Higher estrogen levels. In obese women, higher levels of estrogen, due to the conversion of androgens to estrogen in adipose tissue, can help protect against bone loss, particularly postmenopausal osteoporosis. 2. Fat distribution matters. Subcutaneous fat versus visceral fat. While subcutaneous fat may have a protective effect on bones, visceral fat, fat around internal organs, is linked to increased inflammation, which can lead to negative effects on bone quality. Therefore, the protective effect may vary depending on the type and distribution of body fat. 3. Risk of fractures, falls and fractures. While obese individuals may have higher bone density, they are still at risk of fractures due to other factors. Obesity can increase the risk of falls because of impaired mobility and balance. Fractures, particularly in areas like the ankle, are more common among obese people due to these biomechanical issues. Bone quality. Obesity may improve bone density, but it doesn't always improve bone quality. Even if bones are denser, they may still be at risk of fragility if the microarchitecture of the bone is poor. 4. Secondary osteoporosis, metabolic syndrome, and osteoporosis. Obese individuals may be at risk for secondary causes of osteoporosis due to conditions like type 2 diabetes, which is associated with impaired bone quality despite normal or increased bone density. Conclusion. Obesity is generally associated with lower risk of osteoporosis because of increased bone density and mechanical loading on bones. However, this doesn't mean obese individuals are immune to bone health issues. They may still be at risk for fractures due to factors like poor bone quality, increased fall risk, and metabolic complications. So, while it's largely fact that obesity reduces the risk of osteoporosis, it's not a simple protective guarantee. The statement that BMD, bone mineral density, alone is not sufficient to predict fracture risk is a fact. Here's why. 1. BMD is a key but not sole predictor. BMD as a predictor. BMD is a significant factor in determining fracture risk, as low bone density is closely associated with osteoporosis and increased susceptibility to fractures. The standard method for assessing BMD is the DEXA scan, which measures bone density in specific areas like the spine and hip. Limitations of BMD. While BMD provides valuable information about bone strength, it doesn't account for other critical factors that contribute to fracture risk, such as bone quality, bone geometry, and fall risk. 2. Fracture risk depends on multiple factors. Bone quality. BMD measures bone mass, but it doesn't reflect bone quality, which includes factors like bone microarchitecture, turnover rate, and material composition. A person could have normal or even high bone density, but poor bone quality, which still increases their risk of fractures. Age and gender. Older individuals, especially postmenopausal women, are at higher fracture risk even if their BMD is only moderately low. Similarly, fracture risk is higher for women compared to men at the same BMD levels. History of previous fractures. A previous fracture significantly increases the risk of future fractures, regardless of current BMD. Falls and balance issues. Many fractures, particularly hip fractures, occur due to falls. Factors like muscle strength, balance, and mobility are crucial in determining fracture risk. For example, an elderly person with normal BMD but poor balance and frequent falls is still at high risk for fractures. 3. Fracture risk assessment tools. FRAX tool. The FRAX, Fracture Risk Assessment Tool, is commonly used to estimate an individual's 10-year probability of a major osteoporotic fracture. It integrates BMD with other clinical risk factors like age, gender, smoking, alcohol use, family history, and previous fractures, emphasizing that BMD alone isn't enough to predict risk. 4. Bone geometry and size. Bone shape and structure. The shape and thickness of bones also play a role in fracture risk. For instance, slender bones are more prone to fractures even at a similar BMD compared to thicker bones. Conclusion. While BMD is an important component of fracture risk prediction, it is not sufficient on its own. Fracture risk is a multifactorial issue that also depends on bone quality, personal history, age, lifestyle factors, and the risk of falling. Therefore, it's essential to consider BMD alongside other risk factors for a more accurate assessment of fracture risk. The FRAX, Fracture Risk Assessment Tool, is a widely used tool that calculates an individual's 10-year probability of sustaining an osteoporotic fracture. Developed by the World Health Organization, WHO, FRAX integrates multiple clinical risk factors along with or without bone mineral density, BMD, to estimate fracture risk. It is designed to provide a more comprehensive assessment than BMD alone. Key components of FRAX. FRAX takes into account a combination of clinical factors and optionally femoral neck BMD to calculate the 10-year probability of 1. Major osteoporotic fractures, hip, clinical spine, forearm, or shoulder. 2. Hip fractures specifically. Input factors used in FRAX. The FRAX tool uses the following clinical risk factors along with or without BMD to calculate fracture risk. 1. Age. Older individuals have a higher risk of fractures. 2. Sex. Women generally have a higher fracture risk than men, especially postmenopausal women. 3. Weight and height. These are used to calculate body mass index, BMI, which can influence bone density and fracture risk. 4. Previous fractures. A history of fragility fractures increases the risk of future fractures. 5. Parental history of hip fracture. A family history of osteoporosis or hip fractures increases personal fracture risk. 6. Smoking. Current smoking is a risk factor for lower bone density and fractures. 7. Glucocorticoid use. Prolonged use of corticosteroids, e.g. prednisone, is known to reduce bone density. 8. Rheumatoid arthritis. Individuals with rheumatoid arthritis have a higher risk of fractures. 9. Secondary osteoporosis. This includes conditions such as type 1 diabetes, hyperthyroidism, chronic malnutrition, and liver disease, all of which can contribute to bone loss. 10. Alcohol intake. Excessive alcohol consumption, 3 or more units daily, is associated with higher fracture risk. 11. BM optional. Femoral neck BMD can be inputted if available, but FRAX can still be used without it by relying on clinical risk factors alone. How FRAX works with BMD. When femoral neck BMD is included in the FRAX calculation, it provides a more specific estimate of fracture risk. Without BMD, FRAX can still estimate fracture risk using just the clinical risk factors, making it useful in settings where BMD testing is not available. FRAX outputs. The tool generates 2 key results. 1. 10-year probability of a major osteoporotic fracture. This includes fractures of the hip, clinical spine, forearm, or shoulder. 2. 10-year probability of a hip fracture. Specifically estimates the probability of sustaining a hip fracture. Interpretation of FRAX results. Threshold for treatment. Based on the FRAX score, guidelines often provide thresholds for when preventive treatment for osteoporosis should be initiated. For example, if the 10-year probability of a major osteoporotic fracture exceeds a certain percentage, often 10 to 20%, treatment such as bisphosphonates or other osteoporosis medications may be recommended. Customizable to regions. FRAX calculations are region-specific, as fracture risk varies by population due to differences in genetics, lifestyle, healthcare access, and environmental factors. The tool is calibrated for various countries to reflect local epidemiology. Advantages of FRAX. Holistic risk assessment. Unlike BMD, which only measures bone density, FRAX incorporates multiple clinical factors to provide a more accurate prediction of fracture risk. Accessible. It is widely available online and can be used without a BMD test, making it accessible in resource-limited settings. Personalized treatment decisions. FRAX helps clinicians tailor treatment plans by identifying individuals at high risk for fractures, even if their BMD is not in the osteoporotic range. Limitations of FRAX does not include all risk factors. Important factors like falls, balance, and physical activity, which significantly influence fracture risk, are not included in FRAX. Hip-specific BMD. FRAX typically uses femoral neck BMD rather than spine BMD, which may not capture all types of osteoporosis, such as vertebral fractures in older women. Limited to certain fractures. FRAX focuses on major osteoporotic fractures and hip fractures, but does not address other fracture sites or bone quality measures. When to use FRAX. Primary care settings, to identify individuals at risk for osteoporotic fractures who may need preventive treatment. Osteoporosis screening, for individuals over the age of 40, especially postmenopausal women and older men with clinical risk factors. Decision-making for treatment, helps clinicians determine when to initiate or escalate osteoporosis treatment, especially when BMD results alone are borderline. FRAX in clinical guidelines. Many osteoporosis management guidelines, e.g., by the National Osteoporosis Foundation, European Society for Clinical and Economic Aspects of Osteoporosis, incorporate FRAX into their risk assessment protocols to help make treatment decisions based on individualized risk rather than BMD thresholds alone. In summary, FRAX is a valuable tool for predicting fracture risk, especially when used in conjunction with BMD and other clinical assessments, providing a comprehensive understanding of an individual's risk profile for fractures. The statement that prevention of osteoporosis begins in childhood through achieving higher peak bone mass density is a fact. Here's why. 1. Peak bone mass development. What is peak bone mass? Peak bone mass is the maximum bone strength and density an individual achieves, usually between the ages of 20 and 30. After this point, bone density generally plateaus or declines with age. The higher the peak bone mass, the more bone reserve a person has, which can delay or reduce the severity of osteoporosis later in life. Early bone health. About 90% of peak bone mass is developed by age 18 in girls and by age 20 in boys. This makes childhood, adolescence, and early adulthood critical periods for building strong bones. Tasha 2. Factors influencing peak bone mass. Several factors during childhood and adolescence contribute to achieving higher peak bone mass. Calcium intake. Adequate calcium consumption is crucial for bone development, as calcium is a key building block of bone. Vitamin D. Vitamin D helps the body absorb calcium. Sufficient exposure to sunlight and/or dietary sources of vitamin D are important during childhood. Physical activity. Weight-bearing and muscle-strengthening exercises, e.g., running, jumping, dancing, during childhood help stimulate late bone formation and increase bone density. Nutrition. A balanced diet rich in other bone-healthy nutrients, such as protein, phosphorus, and magnesium, supports bone growth. Hormonal health. Adequate growth hormone levels and puberty timing, especially in girls, play important roles in bone development. Conditions like delayed puberty can negatively affect peak bone mass. 3. Long-term impact on osteoporosis risk. Higher peak bone mass equals lower osteoporosis risk. The higher the bone mass at its peak, the more bone loss an individual can tolerate with age before reaching levels that increase the risk for osteoporosis and fractures. Bone loss with age. After reaching peak bone mass, there is a gradual decline in bone density. For women, this decline accelerates after menopause due to reduced estrogen levels. However, if peak bone mass was high, the effects of bone loss in later life are less severe. Prevention strategies during childhood. Calcium and vitamin D intake, ensuring children get adequate calcium through milk, dairy products, and fortified foods, and vitamin D through sun exposure and supplements if needed, is crucial. Encouraging physical activity. Encouraging active play, sports, and exercises like running and jumping strengthens bones during the critical bone-building years. Avoiding harmful factors. Limiting soda consumption. High phosphorus can interfere with calcium absorption, and avoiding smoking, even in adolescence, supports bone health. Conclusion. Osteoporosis prevention indeed begins in childhood by focusing on maximizing peak bone mass through proper nutrition, physical activity, and a healthy lifestyle. Achieving a higher peak bone mass can significantly reduce the risk of osteoporosis and fractures later in life, making this statement a fact. The pathogenesis of osteoporosis involves a complex interplay between bone resorption, breakdown, and bone formation. The Rankel OPG pathway plays a central role in regulating this balance, particularly in the control of osteoclast activity, which is responsible for bone resorption. Here's a detailed look at how this pathway contributes to osteoporosis. 1. Overview of bone remodeling. Bone remodeling is a lifelong process where old bone tissue is replaced by new bone tissue to maintain bone strength and mineral homeostasis. It involves osteoclasts, cells that resorb break down bone tissue; osteoblasts, cells that form new bone tissue; In osteoporosis, the balance between these processes is disturbed, leading to increased bone resorption compared to bone formation, resulting in bone loss and increased fracture risk. PA2, the Rankel OG pathway. The Rankel OPG pathway is a key regulator of osteoclast differentiation, activation, and survival. It controls the rate of bone resorption and is tightly regulated in normal bone metabolism. Here are the main components. Rankel, receptor activator of nuclear factor Kb ligand. Rankel is produced by osteoblasts and stromal cells in the bone marrow. It binds to RANK, receptor activator of nuclear factor Kb, which is a receptor located on the surface of osteoclast precursors and mature osteoclasts. When Rankel binds to RANK, it promotes the differentiation of osteoclast precursors into mature osteoclasts, activates existing osteoclasts, and prolongs the lifespan of osteoclasts. RANK, receptor activator of nuclear factor Kb. RANK is expressed on osteoclast precursors and mature osteoclasts. When activated by Rankel, it triggers signaling pathways that lead to the formation and activation of osteoclasts, increasing bone resorption. OPG, osteoprotegerin. OPG is a decoy receptor produced by osteoblasts and other cells. It binds to Rankel, preventing it from interacting with RANK. By blocking the Rankel-RANK interaction, OPG inhibits osteoclast formation and activity, thereby reducing bone resorption. 3. Pathogenesis of osteoporosis via the Rankel-OPG pathway. In osteoporosis, the balance between Rankel and OPG is disrupted, leading to excessive bone resorption. Here's how it happens. Increased Rankel expression. Various factors, such as aging, hormonal changes, e.g. postmenopausal estrogen deficiency, and certain diseases, can increase the production of Rankel by osteoblasts and stromal cells. Estrogen deficiency. In postmenopausal women, the decrease in estrogen levels leads to an increase in Rankel expression and a decrease in OPG levels, tipping the balance toward enhanced osteoclast activity and bone resorption. Cytokines. Inflammatory cytokines such as TNF-α, IL-1, and IL-6 increase Rankel expression, promoting osteoclast formation and activity, which accelerates bone loss. Decreased OPG levels. Simultaneously, factors like estrogen deficiency and certain medications, e.g. glucocorticoids, can reduce OPG production, diminishing its protective effect against excessive bone resorption. Glucocorticoids. These medications not only reduce OPG production, but also directly increase osteoclast lifespan, further enhancing bone breakdown. Resulting bone loss. The upregulation of Rankel combined with the downregulation of OPG leads to increased osteoclast formation and activity, which causes accelerated bone resorption. Over time, this imbalance reduces bone mass and microstructural integrity, leading to osteoporosis. Half 4. Factors influencing the Rankel-OPG pathway in osteoporosis. Several systemic and local factors modulate the Rankel-OPG pathway and contribute to osteoporosis development. Hormonal influence. Estrogen. Estrogen suppresses Rankel expression and promotes OPG production. Estrogen deficiency in postmenopausal women increases Rankel expression and decreases OPG levels, leading to increased osteoclast activity. Parathyroid hormone, PTH. Intermittent PTH exposure stimulates bone formation, but chronic elevation, e.g. in hyperparathyroidism, increases Rankel expression and enhances bone resorption. Cytokines and inflammation. Chronic inflammation, often seen in diseases like rheumatoid arthritis, increases the production of pro-resorptive cytokines, TNF-α, IL-1, IL-6, enhancing Rankel expression and bone resorption. Medications, glucocorticoids. These increase Rankel expression and reduce OPG, promoting osteoclast formation and bone loss. Bisphosphonates. These drugs inhibit osteoclast activity and can indirectly affect the Rankel-OPG pathway by reducing bone resorption. 5. Therapeutic implications. Targeting the Rankel-OPG pathway. Given the central role of the Rankel-OPG pathway in osteoclast regulation, it has become a key therapeutic target for osteoporosis treatment. Denosumab, a monoclonal antibody that mimics OPG by binding to Rankel and preventing its interaction with RANK. Denosumab inhibits osteoclast formation and activity, reducing bone resorption and increasing bone density. Use in osteoporosis. Denosumab is used to treat postmenopausal osteoporosis, reducing the risk of fractures by inhibiting the Rankel-RANK interaction. Other therapies. Bisphosphonates, though they don't directly target the Rankel OPG pathway, they inhibit osteoclast-mediated bone resorption and are a first-line treatment for osteoporosis. Selective estrogen receptor modulators, SERMs. These mimic estrogen's effects on bone by decreasing Rankel expression and promoting OPG production, thus reducing bone resorption. 6. Summary of the Rankel OPG pathway in osteoporosis. Normal bone remodeling. In healthy bone, Rankel and OPG are balanced, allowing for the proper formation and resorption of bone. In osteoporosis, increased Rankel and decreased OPG disrupt this balance, leading to increased osteoclast activity, excessive bone resorption, and reduced bone mass. Therapeutic target. Blocking Rankel, e.g. with denosumab, reduces osteoclast activity, helping to prevent bone loss in osteoporosis. In conclusion, the Rankel OPG pathway is critical in regulating osteoclast activity and bone resorption. Its dysregulation plays a key role in the pathogenesis of osteoporosis, particularly in conditions like postmenopausal osteoporosis. Therapeutic strategies targeting this pathway have proven effective in managing osteoporosis and preventing fractures. Updated Guidelines for the Diagnosis, Assessment, and Management of Osteoporosis, 2023-2024. The guidelines for osteoporosis management continue to evolve based on the latest research and clinical practices. Below is a summary of the current updated recommendations for the diagnosis, assessment, and management of osteoporosis, incorporating best practices as of 2023 to 2024. 1. Diagnosis of osteoporosis. Osteoporosis is diagnosed based on bone mineral density, BMD assessment, clinical risk factors, and the presence of fragility fractures. TASHTA 1.1 BMD measurement, DXA, gold standard test, dual energy X-ray absorptiometry, DXA remains the gold standard for diagnosing osteoporosis. Diagnostic criteria, WHO, normal, T-score minus 1.0, osteopenia, low bone mass, T-score between minus 1.0 and minus 2.5, osteoporosis, T-score minus 2.5, severe osteoporosis, T-score minus 2.5 with one or more fragility fractures. 1.2 Indications for DXA scanning. Routine DXA scanning is recommended for women aged 65 years and older, postmenopausal women under age 65 with risk factors, e.g., family history of fractures, low body weight, smoking, men aged 70 and older, younger men 50 to 69 years with clinical risk factors, adults with a history of fragility fractures, patients on long-term glucocorticoid therapy, 12 3 months, individuals with other secondary causes of osteoporosis, hyperthyroidism, chronic kidney disease. 2. Assessment of fracture risk. Assessing fracture risk involves clinical risk factors, BMD, and the use of validated tools such as FRAX, Fracture Risk Assessment Tool. 2.1 FRAX Tool. FRAX estimates a 10-year probability of major osteoporotic fractures and hip fractures based on clinical risk factors and, optionally, femoral neck BMD. Threshold for treatment. Patients with a 10-year probability of major osteoporotic fractures to 20% or hip fracture 3%, based on FRAX with BMD, are generally candidates for treatment. NAS 2.2 Clinical risk factors for fractures. Age. Older age increases fracture risk. Gender. Women, especially postmenopausal, are at higher risk. History of fragility fracture. Prior fracture increases the risk of future fractures. Family history of osteoporosis or fractures. Smoking and alcohol consumption. Current smoking and excessive alcohol intake, 3 units a day. Glucocorticoid therapy. Chronic diseases, rheumatoid arthritis, diabetes, malabsorption syndromes. 2.3 Vertebral fracture assessment, VFA. For patients with suspected vertebral fractures, e.g., height loss, back pain, vertebral fracture assessment via spine X-ray or DXA can help confirm silent fractures, particularly in older adults. Management of osteoporosis. 3.1 Lifestyle modifications. Lifestyle modifications are fundamental for all patients to prevent further bone loss and reduce fracture risk. Adequate calcium intake, 1,000 to 1,200 milligrams per day from diet and supplements if necessary. Vitamin D supplementation, 800 to 1,000 IU a day to maintain serum levels of 25-hydroxyvitamin D, 30 nanograms per milliliters. Regular weight-bearing exercise, Encourage activities such as walking, dancing, or strength training at least 3 times a week. Smoking cessation. Smoking is an independent risk factor for osteoporosis and fractures. Moderate alcohol intake. Limit alcohol consumption to 2 units a day. 3.2. Pharmacological treatment. Pharmacological therapy is recommended for patients with osteoporosis diagnosed by BMD, T-score 9 is 2.5, those with a history of fragility fractures, or those at high fracture risk, based on FRAX. 3.2.1 First-line treatments, bisphosphonates, oral options, alendronate, risdronate. IV options, zoledronic acid, ibandronate. Duration. Bisphosphonates are typically used for 3 to 5 years, after which a drug holiday may be considered if fracture risk reduced. Monitoring. BMD should be reassessed after 2 to 3 years of therapy. Denosumab, a monoclonal antibody that inhibits rankle, preventing osteoclast formation, administered as a subcutaneous injection every 6 months. Note, treatment discontinuation can result in rapid bone loss, so continuous treatment or switching to another agent is recommended after stopping denosumab. 3.2.2 Alternative treatments. Selective estrogen receptor modulators, SERMs. Raloxifene is recommended for postmenopausal women, particularly those at risk for breast cancer. Teriparatide, PTH analog, an anabolic agent used for patients with severe osteoporosis, T-score -3.5 or multiple fractures. Romosozumab, a monoclonal antibody that inhibits sclerostin, promoting bone formation and reducing resorption. Recommended for high-risk patients or those who fail other therapies. Part 3.2.3 Hormone replacement therapy, HRT, estrogen therapy. Can be considered in younger postmenopausal women for fracture prevention, but is not a first-line treatment due to potential cardiovascular and cancer risks. Part 3.3 Monitoring and follow-up, BMD monitoring. Repeat DXA every 1 to 2 years to assess the effectiveness of treatment, especially in high-risk individuals. Biochemical markers, serum C-telopeptide, CTX, and procollagen type 1 N-terminal propeptide, P1NP, can be used to monitor bone turnover. Reevaluation of risk factors, continual reassessment of fracture risk, medication side effects, and adherence to therapy. 4. Management of special populations. 4.1 Glucocorticoid-induced osteoporosis. Patients on long-term glucocorticoids, 5 mg prednisone or equivalent daily for 3 months or more, are at increased risk for osteoporosis. Preventive measures. Start bisphosphonates or other anti-resorptive agents at the onset of glucocorticoid therapy. 4.2 Men with osteoporosis. Men with osteoporosis should be evaluated for secondary causes, e.g. hypogonadism, vitamin D deficiency. Treatment, similar to women, with bisphosphonates and denosumab being first-line options. 5. Special considerations for older adults. Fall prevention. Ensure a multifactorial approach, including home safety evaluations, physical therapy, and management of vision and hearing impairments. Calcium and vitamin D. Ensuring adequate intake is crucial, but excessive calcium, especially from supplements, may increase cardiovascular risks. Conclusion. The updated guidelines for osteoporosis emphasize the importance of comprehensive risk assessment using tools like FRAX and DXA, combined with individualized treatment plans that include both lifestyle modifications and pharmacological interventions. Newer therapeutic agents such as denosumab, romosozumab, and teriparatide offer more targeted treatment options for high-risk patients. Early diagnosis, risk stratification, and adherence to treatment are key to reducing fracture risk and improving quality of life in individuals with osteoporosis. Anabolic agents such as teriparatide, PTH analog, and abaloparatide are used in the treatment of severe osteoporosis. These drugs stimulate bone formation by promoting the activity of osteoblasts, the cells responsible for bone formation. However, their use is typically limited to a maximum of 2 years due to several reasons. 1. Risk of osteosarcoma. Preclinical animal studies, long-term use of anabolic agents, particularly teriparatide, has been associated with an increased risk of osteosarcoma, a rare type of bone cancer, in animal studies, specifically in rats. Although this has not been conclusively shown in humans, the potential risk has led to a recommendation to limit the duration of therapy. Human data. Osteosarcoma cases in humans after teriparatide use are extremely rare. However, to minimize any potential risk, treatment duration is capped at 24 months. Diminishing returns over time. Bone formation response declines. The anabolic effect of agents like teriparatide is most pronounced in the first 12 to 18 months of therapy. After this period, the bone formation response tends to diminish. Continued use beyond 2 years does not result in significant additional benefits in terms of bone density gains, and maintaining bone mass is better achieved with anti-resorptive therapy following the anabolic phase. TOS 3. Transition to anti-resorptive therapy. After completing 2 years of anabolic therapy, it is generally recommended to transition to an anti-resorptive agent, e.g., bisphosphonates or denosumab, to maintain the bone mass gained during the anabolic treatment. Without this transition, there can be a rapid loss of the new bone formed and fracture risk may increase. 4. Regulatory guidelines. Clinical guidelines and regulatory authorities, such as the FDA, limit the use of anabolic agents to 2 years based on the available safety data and the diminishing therapeutic effects after this period. Hammer 5. Targeting specific high-risk groups. Anabolics are typically reserved for patients at high fracture risk, such as those with multiple vertebral fractures, very low bone density, T-score below -3.5, or those who have failed anti-resorptive therapy. These patients benefit most from the short-term anabolic boost, but once bone formation peaks, long-term maintenance requires different treatment strategies. Conclusion. Anabolic agents are highly effective in increasing bone formation and density in individuals with severe osteoporosis, but due to the risks of osteosarcoma, diminished returns over time, and the need for maintenance with anti-resorptives, their use is limited to 2 years. After this period, switching to a maintenance therapy like bisphosphonates or denosumab is essential to sustain the benefits. Bisphosphonates are the most commonly prescribed class of drugs for the treatment and prevention of osteoporosis. They work by inhibiting bone resorption, thereby increasing bone mineral density, BMD, and reducing the risk of fractures. 1. Mechanism of action. Bisphosphonates have a high affinity for hydroxyapatite, the mineral component of bone, and primarily affect osteoclasts, the cells responsible for bone resorption. They inhibit bone resorption through two main mechanisms: inhibition of osteoclast activity. Bisphosphonates prevent osteoclasts from adhering to the bone surface and reduce their lifespan, which decreases bone resorption. Induction of osteoclast apoptosis. Some bisphosphonates, particularly nitrogen-containing ones, induce programmed cell death, apoptosis, in osteoclasts, further reducing bone breakdown. As a result, bone resorption slows down, allowing bone formation to either stay the same or increase, thus improving bone density over time. 2. Types of bisphosphonates. Bisphosphonates are divided into non-nitrogen containing and nitrogen containing bisphosphonates, with the latter being more potent. They are available in oral and intravenous forms. Non-nitrogen containing bisphosphonates: etidronate, didronel; clodronate, bonefos; had nitrogen-containing bisphosphonates, more commonly used due to higher efficacy: alendronate, Fosamax, oral, administered weekly; risdronate, Actonel, oral, administered weekly or monthly; ibandronate, Boniva, monthly or IV every 3 months; zoledronic acid, reclassed Zometa, IV, administered once yearly for osteoporosis. Ta3. Indications for use. Bisphosphonates are used in a variety of conditions that lead to increased bone resorption. Postmenopausal osteoporosis, primary indication to reduce vertebral, non-vertebral, and hip fracture risk. Osteoporosis in men, effective for treating osteoporosis in men, especially those at high fracture risk. Glucocorticoid-induced osteoporosis, prevents bone loss in individuals on long-term glucocorticoid therapy. Paget's disease of bone, used to reduce excessive bone turnover. Bone metastases. In cancer patients, bisphosphonates are used to prevent skeletal complications like fractures or hypercalcemia. 4. Efficacy of bisphosphonates. Bisphosphonates have been extensively studied and shown to increase BMD. By reducing bone resorption, they significantly increase BMD at the spine and hip, reduce fracture risk, Vertebral fractures, reduction by up to 40 to 70%. Non-vertebral fractures, reduction by up to 20 to 40%. Hip fractures, reduction by 40 to 50%. Hash 5, duration of therapy. Typical duration. Bisphosphonates are often prescribed for 3 to 5 years. Drug holiday. After 3 to 5 years of therapy, many patients are advised to take a drug holiday if their fracture risk is moderate. During this period, treatment is paused to reduce the risk of rare side effects, e.g., atypical femoral fractures or osteonecrosis of the jaw. But fracture protection can persist for a while due to bisphosphonates' long half-life in bone. High-risk patients. In patients at very high risk for fractures, treatment may continue beyond 5 years with regular reassessments. 6. Side effects and risks. While generally well tolerated, bisphosphonates are associated with several potential side effects. 6.1. Gastrointestinal side effects. Oral bisphosphonates. Esophagitis. Irritation of the esophagus is the most common complication with oral bisphosphonates, particularly if the medication is not taken correctly, e.g., not staying upright after taking the pill. Gastric ulcers. Oral bisphosphonates can also cause gastric irritation or ulcers. 6.2. Acute phase reaction, IV bisphosphonates. Intravenous bisphosphonates like zoledronic acid can cause flu-like symptoms, fever, muscle pain, after administration, which usually lasts 1 to 3 days and can be treated with analgesics like acetaminophen. 6.3. Rare complications. Osteonecrosis of the jaw, ONJ, a rare but serious side effect where the jawbone fails to heal after minor trauma such as a tooth extraction. It is more common in cancer patients receiving high-dose bisphosphonates. Prevention. Good oral hygiene and dental checkups before starting bisphosphonates can reduce the risk. Atypical femoral fractures. Long-term bisphosphonate use, typically 5 years, has been associated with rare atypical fractures of the femur, often preceded by pain in the thigh or groin. Monitoring. Patients on long-term therapy should be monitored for signs of thigh pain, and treatment discontinuation should be considered if an atypical fracture occurs. Hypocalcemia. Especially with intravenous bisphosphonates, there can be a risk of hypocalcemia, low calcium levels, particularly in patients with low vitamin D levels. Patients should ensure adequate calcium and vitamin D intake. 7. Contraindications. Esophageal disorders. Oral bisphosphonates are contraindicated in patients with conditions such as esophageal stricture or achalasia. Hypocalcemia. Bisphosphonates should not be used in patients with untreated hypocalcemia. Severe renal impairment. Bisphosphonates, especially IV forms, are contraindicated in patients with creatinine clearance 30 to 35 milliliters per minute as they are excreted by the kidneys. 8. Administration guidelines. To minimize side effects and maximize efficacy, bisphosphonates must be taken correctly. Oral bisphosphonates. Take first thing in the morning with a full glass of water. Stay upright, sitting or standing, for at least 30 to 60 minutes after taking the pill to prevent esophageal irritation. Do not eat, drink, except water, or take other medications for 30 to 60 minutes. Intravenous bisphosphonates. Zoledronic acid is administered as a once-yearly IV infusion, typically in a hospital or clinic setting. Ibandronate can be given every 3 months as an IV infusion. 9. Monitoring. Bone mineral density, BMD. Reassess BMD every 1 to 2 years to monitor treatment efficacy. Biochemical markers. Bone turnover markers, e.g. serum CTX, P1NP, can be used to assess response to therapy. Serum calcium and renal function, particularly important before administering intravenous bisphosphonates. Conclusion. Bisphosphonates are highly effective in reducing fracture risk and increasing BMD in patients with osteoporosis. They are the first-line treatment for most cases of postmenopausal and glucocorticoid-induced osteoporosis, as well as in men. While generally safe, their long-term use should be carefully monitored due to potential rare but serious side effects. Careful administration and follow-up, including consideration of drug holidays, can help optimize outcomes and minimize risks. Biological drugs for managing osteoporosis are generally targeted therapies used for specific patient populations or in cases where traditional treatments are not effective. Here are some key biological drugs used. 1. Denosumab, Prolia, Xgeva. This monoclonal antibody targets RANKL, receptor activator of nuclear factor kappa B ligand, which is involved in bone resorption. It helps reduce bone loss and fracture risk. 2. Teriparatide, Forteo. This is a recombinant form of parathyroid hormone, PTH. It stimulates bone formation and is typically used in patients with severe osteoporosis or those who cannot tolerate other treatments. 3. Abaloparatide, Tymlos, another PTH analog similar to teriparatide that promotes bone formation and is used for osteoporosis treatment. 4. Romosozumab, Evenity. This monoclonal antibody targets sclerostin, a protein that inhibits bone formation. It both increases bone formation and decreases bone resorption. These biological drugs are usually considered when osteoporosis is severe or when other treatments have failed. They are administered via injection and typically used in conjunction with calcium and vitamin D supplements.